minutes, 8 minutes to present their research, and after 6 minutes, you will be notified that 2 minutes are remaining, and after completion of total 8 minutes, there will be a 2 minute question answer session by the judge, and then we'll switch to the next speaker. I request everyone to change their names. Like I can see Galaxy 8 and Realme and other people. So please change their names to the original, like your personal name. And yeah, we'll be starting in 10 minutes. If you have any query, please unmute yourself and you can ask. And after each slide of the presentation, you have to tell me to change it. Like once you finish the first slide, then let me know. Say next, and then I'll change to the next slide. Please ask me if you have any other queries. Our judge for today is Dr. Manisha. Ma'am, am I audible to you? Ma'am, please switch on your audio.
Hello, am I audible?
Yes, you are.
Hello.
Yes, yes, yes.
Yes. Can we know our turn so that we can be prepared for our who will be the next
Uh,
presenter?
so yeah, once I start, I'll
Okay.
let you know the next speaker. So if I like once we start with our first speaker, then I'll let you know who is the next speaker so that they can be prepared with it.
Okay. Okay. Thank you.
Yeah. There is some technical issue on the judges' side, so we'll be starting the presentations soon. And I would request everyone to switch on their video camera once we start with the research presentations.
અત્યારે તો નતો આવતો એમ. ના ના નથી આવતો. ઇયરફોનમાં તો નથી આવતો. હેલો. હા મેમ. હા મેમ. હા.
Hello, ma'am. Yeah. Is everything okay out there? Like, is the audio, video okay?
ફર્સ્ટ
Hello.
કન્ટેસ્ટન્ટ છે હા બરાબર છે આનું અરે 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 બધું લઈને આવી છું મેં ખાલી એ લોકોના ટોપિકના નામ માંગ્યા હતા એમની પાસે કરી શકું ને થોડું વધારે સીધું હા બસ 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 ઓકે ઇઝ ઓકે ઓકે થેન્ક યુ
Ma'am, can we start?
યસ પ્લીઝ
Okay.
હા તારો નંબર પૂર્વી શું થઈ ગયું
Ma'am, is the screen visible?
હા એ લોકો મોકલશે
Hello.
યસ
Ma'am, is the screen visible?
યસ યસ
Okay. 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 So now participants will start with the first research presentation. Dr.
Yes.
Akruti, you will be
Okay.
having in total 8 minutes to present your presentation. After 6 minutes, I'll notify you that 2 minutes are remaining, and after that, there will be 2 minutes question answer session from the judge's side.
અહીં બેસો વાંધો નહીં લઈને વાંધો
Dr. Akruti.
હેલો
Hello.
વેર ઇઝ આકૃતિ
Okay.
if she is not login please pass over next contestant
Okay. Okay, ma'am. Dr. Ankit. Do we have Dr. Ankit?
Yes, sir, I am present.
Okay.
Am I audible, sir?
Yes, yes, it's audible.
yes please please
Okay.
Okay, you can start, Dr. Ankit.
Yes, sir. Sir, some. Okay. I'll start. Good afternoon. Good afternoon, everybody. Good afternoon, ma'am. My name is Dr. Ankit Mankad. I'm third year resident of Department of Anesthesiology, Sumandip Vidyapith, Piparia, Vadodara. I will be presenting my topic. My topic is an observational study to observe effect of ketamine gargle in post-operative sore throat, cough, and hoarseness of voice following endotracheal intubation in patients undergoing surgery under general anesthesia.
yes
Next slide.
proceed
We'll start with introduction. Patients who are given general anesthesia, majority of them undergo endotracheal intubation, either for long duration or short duration. This results in injury to airway mucosa or vocal cords, which may be the contributing factor in post-operative sore throat, hoarseness of voice, and cough. The reported incidence of post-operative sore throat varies from 21% to 65%. Hoarseness of voice and cough has also been reported with incidences varying from 4 to 42%. Numerous non-pharmacological trials like smaller size endotracheal tubes, lubricating endotracheal tube with water-soluble jelly, minimizing intracuff pressure, etc. have been used for attenuating post-operative sore throat, hoarseness of voice, and cough with variable success. The pharmacological measures include beclomethasone inhalation and gargling with azulene sulfonate. NMDA receptors are found in the central nervous system as well as the peripheral nerves, which on activation result in nociceptive behaviors and contribute to inflammatory pain. Experimental studies showed that peripherally administered NMDA receptor antagonists are involved with anti-nociception and anti-inflammatory cascade. Therefore, we suppose that ketamine being NMDA receptor antagonist is likely to act as an anti-nociceptive and anti-inflammatory agent in attenuating post-operative sore throat, hoarseness of voice, and cough after endotracheal intubation. Ketamine is routinely used, easily available, and cost-effective drug. Gargle, being an acceptable and simple method of administration of ketamine, we intend to observe the effect of ketamine gargle in post-operative sore throat, hoarseness of voice, and cough after endotracheal intubation. Now, aims and objectives of my study. The aim is to study the effect of ketamine gargle in post-operative sore throat, hoarseness of voice, and cough following endotracheal intubation. The main objectives are to observe the incidence and severity of sore throat, to observe the incidence and severity of hoarseness of voice, and to observe the incidence and severity of cough. The materials and methodology. After the approval from the Institutional Ethical Committee from Dheeraj Hospital and Sumandeep Vidya University, I have started the prospective study, which was conducted in the Department of Anesthesiology from 2018 to 2020. The inclusion criteria for my study was the patients willing to sign the written informed consent form, patients of either gender, aged between 18 to 55 years, patients undergoing elective surgical procedure of not lasting more than 1 hour and 30 minutes duration under general anesthesia, and patients belonging to ASA 1 and 2 grades. The exclusion criteria includes patients with history of prior sore throat, patients with known upper respiratory tract infection or lower respiratory tract infection, patients with known allergy, sensitivity, or any other form of reaction to the study drug, patients with anticipated difficult airway, that is Malampati grade 3 and 4, patients with poor cardiovascular and respiratory reserve, and patients with ASA 3 or more. Written informed consent obtained from all the patients who fulfilled the inclusion criteria and were willing to participate in the study. Pre-anesthetic checkup was done.
Ankit, 1 minute, Ankit.
Yes,
you
ma'am.
just go through all things are written in your slide.
Yes, ma'am.
You have a period of only 8 minutes.
Yes, ma'am.
About 5 minutes are over. Hai
Yes, ma'am.
na?
I will do it quickly. And the pre-operative anesthetic checkup was done, and the procedure of general anesthesia was explained to patients. Patients were kept NBM for 8 hours, and baseline vitals were recorded.
Okay.
Intraoperatively, we had a group of 25 patients each in group K, where group K and C, where in group K, the patients received 50 milligram of ketamine, that is 1 ml of ketamine in 29 ml solution of normal saline. And in group C, we gave gargles by 30 ml of normal saline.
Okay.
Patients were assessed at 1 hour, 2 hour, 4 hour, and 24 hours post extubation for incidences of sore throat, hoarseness of voice, and cough. The scaling, the grading system was according to the 4-point grading scale: 1 at 0, 1, 2, and 3, where 0 indicated no sore throat, 1 is mild, 2 is moderate, and 3 is severe. Similarly, in the hoarseness of voice, 4-point grading scale, with no hoarseness of voice, with mild hoarseness of voice, moderate hoarseness of voice, and severe, which was recognizable at the time of interview.
Okay.
Cough was graded also according to 4-point grading scale, where there was no cough, 1 is mild, 2 is moderate, and 3 is severe. Now, the results and discussion. The results which I got from my study was the here I have given the table where the clinical outcome analysis has been shown, where 3 total results are shown, where post-operative sore throat, hoarseness of voice, and grading of cough has been given. In the very first post-operative sore throat, we have observed that from 4 hours onwards, there was no statistically significant difference in the terms of post-grading in both K and C group. However, in the beginning and at the 2 hours, there was significant difference in the observation of post-operative sore throat grading, where we got the p-value less than 0.05. and after that there was no significant difference at 4 hours and 24 hours in both the groups.
Dr. Ankit, 6 minutes are over. Last 2 minutes are
Okay.
left.
Okay. Next slide. In the hoarseness of voice, there was a significant difference observed in severity of hoarseness of voice till 24 hours, where p-values were found less than 0.05, and this showed that ketamine gargles were very effective in reducing the hoarseness of voice till 24 hours. So here the p-value at 1 hour, 2 hour, and 4 hours are less than 0.05, and it only increases after 24 hours of observation. Next slide.
Okay.
In cough, unlike the previous both outcomes, here we can see that cough was attenuated for 1 hour and 2 hours, but after 4 hours and 24 hours observation, we saw that cough in both the study groups K and C was almost equivalent. So there was no effect of ketamine gargles on at 4 and 24 hours of observation.
Okay.
From our study, thus we can conclude that ketamine gargle significantly reduces incidence and severity of post-operative sore throat, hoarseness of voice, and cough in patients following endotracheal intubation in the patients undergoing surgeries under general anesthesia. Thank you.
Okay. Okay, Ankit, which are the agents
Yes,
pharmacological agents used in the anesthesia to attenuate the post-operative sore throat?
Madam, to attenuate the sore throat, we can use lignocaine, lignocaine jelly. We can apply on the endotracheal tube to attenuate the sore throat or cough post-endotracheal intubation. Next thing is we can use the steroids like dexamethasone or beclomethasone. Both can be used, and those studies have also been performed earlier. We can also use NSAIDs, IV NSAIDs like diclofenac can also be given to attenuate the post-operative sore throat or pain in throat.
Okay. Okay. Have you measured the intracup pressure?
No, madam. In our study, we have not measured the intracup pressure.
Okay. Okay. Thanks.
Thank you, madam.
Do we have Dr. Arpit?
Yes, sir. I am here, sir. Present.
Okay. Okay, Dr. Arpit, you can start.
Okay. Good evening, everyone. Good evening, ma'am. Ma'am, my study is randomized double-blind control study comparing bupivacaine 0.125% and ropivacaine 0.2% for labor epidural analgesia. Of all labor analgesic techniques, epidural analgesia is the most effective form of analgesia and has become the gold standard in obstetric care. Bupivacaine is commonly used for labor epidural analgesia because of its long duration of action and relative motor sparing effect when compared with other local anesthetics. Ropivacaine, a newer local anesthetic released in 1996, has similar pharmacokinetic and pharmacodynamic properties as bupivacaine, and this newer local anesthetic confers less lower extremity motor block than the bupivacaine after epidural administration, which may be advantageous. Next slide. Aims and objectives of my study is to pursue and to quantify the advantages of ropivacaine over bupivacaine and to know the onset of action, duration of action, hemodynamic stability, and duration of first and second stage of labor, and adverse effect varies from bupivacaine to ropivacaine. Next slide. Study was performed in 18 early paras women of ASC status 1 and status 2 belonging to age group of 20 to 30 years as per inclusion criteria, and patients were divided into two groups of 40 each. Group R, that is ropivacaine, and group B, that is bupivacaine. Once the women were enrolled in the study, a written informed consent was obtained from them, and randomization was done by asking the patient to select a sealed envelope which had code for either of the drugs. Next slide. Next. My sample size is calculated on the basis of my standard references by Pedalvares and Nagrales and Chandak Srivastanan in 2013, where the mean time for duration of second stage was 33 and 27, respectively, for group R and B. And the calculations are as shown below. Next slide. My results are the demographic variations are not significant in any of the group. We can see in the table that the age groups in the R, that is ropivacaine group and bupivacaine group, the p-value is not significant. Height and same as for weight also. Next slide. The duration of stage of labor and the effect of drug. There is significant difference as we can see that in the stage 2 of the labor, in the ropivacaine, that is the group R, we have find the mean time of 34.21, and in bupivacaine that is 44.21. So we can have the significant difference. But the motor block is seen, previous slide. The motor blocks are seen easily. Next. These are my references.
Okay. Yes. Arpit, you have used ropivacaine and bupivacaine in the labor analgesia. At
Yes.
which level you have put the catheter?
Okay, ma'am. Basically, we have assessed the site before insertion of the needle. We have generally put the L2, L3 space or L3, L4 space.
Yes.
Which is more
And,
palpable.
okay. Any changes in the neonatal ABGA score or any problem?
Ma'am, we didn't notice any significant changes in ABGA score after till the 10 minutes of the delivery of the baby in both of the group.
Okay. Okay. And how you have a ropivacaine 0.2%. You have that vial, or you have taken it from 0.75% or all?
No,
Ampoule.
ready-made preparation for ropivacaine, but we have double diluted the bupivacaine as we have available only 0.5% of bupivacaine. So for 0.125% we have double diluted it.
Okay. Okay. Okay.
I would request all the participants to keep their cameras on. And so, yeah, moving on to the next participant. Do we have Dr. Avni?
Yes, I'm here.
Okay.
Sorry, that's not
Okay,
me.
okay.
Uh,
Dr. Avni Patel, not Avni Vedya.
yeah, yeah. Sorry.
Do we have Dr. Avni Patel?
She is not there. Just leave. Whenever she came, just enroll her.
Okay, okay, madam. Okay, Avni Vedya. Yeah.
Yeah.
Okay, you can start.
Yeah. Good afternoon, all. Good afternoon, ma'am. I am Dr.
Yes.
Avni Vaida, third year resident from Department of Anesthesiology, Sumandeep. My topic for today is an observational study to compare the effects of esmol and diltiazem in attenuating the hemodynamic response to laryngoscopy and endotracheal intubation.
Okay.
Introduction. Laryngoscopy and endotracheal intubation are one of the two most important parts of anesthetic management. They provide control of airway during general anesthesia. They can cause transient but marked sympathetic response, which manifests as an increase in heart rate, both systolic and diastolic blood pressure, intraocular and intracranial pressure. These changes are seen maximum immediately after intubation. These changes are mainly due to increase in the release of catecholamine and mechanical stimulation causing reflex responses in cardiorespiratory systems. Although these effects are short-lived, they may have detrimental effect on high-risk patients, such as patients with coronary artery disease, uncontrolled hypertension, poor cardiac resound, IHD, and intracranial aneurysms. Various non-pharmacological and pharmacological methods are invoked to control this hemodynamic response. Other agents which can be used to attenuate stress response are topical lignocaine, deeper plane of anesthesia by inhalational agents, narcotics like fentanyl, afentanyl, ramifentanil, magnesium sulfate, calcium channel blockers, vasodilators like nitroglycerin, etc. can also be used. Esmolol is a cardioselective beta-adrenergic receptor antagonist, which is water-soluble, has rapid onset, and is ultra-short-acting, having elimination half-life of 9 minutes, with proven efficacy to provide hemodynamic stability during laryngoscopy and tracheal intubation. Diltiazem, a calcium channel blocker with rapid onset of action, has been used extensively to maintain perioperative hemodynamic stability. This drug acts by causing peripheral vasodilatation and by blocking the release of catecholamines and thereby reducing the sympathetic activity. The various pharmacological and non-pharmacological approaches mentioned above for attenuation of hemodynamic response to intubation are not entirely satisfactory. Hence, search for ideal agents to attenuate the hemodynamic responses to intubation is still continuing. It has also been noted that increase in BP and heart rate, which occurs as a result of sympathetic discharge in response to laryngotracheal stimulation, may further get enhanced and prove dangerous to patients with hypertensive and ischemic heart disease. Hence, the present study was undertaken to evaluate the ability of diltiazem and esmolol in attenuating the cardiovascular responses to tracheal intubation. Aims and objectives of the study. Aim is to compare the effect of diltiazem and esmolol in attenuating the cardiovascular responses to tracheal intubation and emergence from anesthesia. Objective is to observe the hemodynamic parameters in the form of pulse rate, systolic BP, diastolic BP, and mean blood pressure to observe the side effects, if any. Materials and methodology. The inclusion criteria of the study are all patients who are posted under general anesthesia, age between 18 to 60 years of either sex, patients willing to give written informed consent, patient with Malampati grade 1 and 2. Exclusion criteria are patient's refusal, patient with a history of any cardiovascular, pulmonary, hepatic, renal disease, and with bleeding disorders, patient on any antihypertensive or cardiovascular medications, coexisting systemic illness like diabetes, pregnant woman, or any patient with difficult intubation. Study population. After obtaining permission and clearance from the ethical committee, this observational study was conducted over 50 patients in the Department of Anesthesiology of Dheeraj Hospital. Selected patients were allocated to any of the two groups according to indications, with 25 patients in each group. Group E was the group which received esmolol 1 mg per kg IV, and Group D was the one patients that received diltiazem 0.2 mg per kg IV. These drugs were given 2 minutes before laryngoscopy and endotracheal intubation. All the patients were kept nil by mouth for at least 6 hours preoperatively before induction of anesthesia for surgery. Procedure. Patient was shifted to OT and IV line was secured. A slow infusion of RL was started. The patient was connected to all the multipara monitors. Pre-medications in the form of injection ondansetron 0.1 mg per kg, injection glycopyrrolate 0.004 mg per kg, injection midas 0.2 mg per kg, and fentanyl 1 to 2 mg per kg was given. Patients were pre-oxygenated with 100% oxygen. According to clinical indications, 25 were given drug esmolol, and other 25 patients were given drug diltiazem. After 1 minute, anesthesia was induced with thiopentone sodium 5 mg per kg, followed. After the loss of consciousness, direct laryngoscopy was performed, non-depolarizing muscle relaxants. Next was changes in the diastolic blood pressure between the two groups. Even on the diastolic blood pressure, esmolol proved to be better than diltiazem. Next slide. Next slide. Yeah. Changes in mean arterial pressure between diltiazem and esmolol group. Here also esmolol was better than diltiazem in attenuating the mean arterial pressure. Next, please. Discussion.